This
if
conference will
somebody
now be recorded.
joins later, then they can see the recordings. Some very short housekeepings from myself. So the webinar will be recording. So later on it can be seen or shared within your network, or actually it will be also posted on the YouTube. I'm happy to see that 13 persons joined this webinar. Last year it was, I think, 6 persons. This year we try another subject because probably the last year's one was too specific. I'm really looking forward to this presentation because previously we ran some questionnaires with our members, and it is a big problem, especially in the Balkans, the access to treatment. And I think that there will be an excellent background what Stanimir can provide us. Stanimir was a presenter at our general meeting in Barcelona, I think in 2015. So probably some of you might know him, and I'm really happy that he accepted our invitation in these challenging times. Stanimir comes from Bulgaria. He is the founder and chairperson of the National Patient Organization in Bulgaria and the Secretary General of the PACT and the CE4. I would not like to steal more time from Stanimir. The floor is yours. I'm making you as a presenter so you can easily share your slides.
Because I have them in Teams, so probably I first have to find them.
Yes, so you are a presenter now. I received a version from Alexander, so if it is more convenient for you, I can share my screen, and you can just say me when you need to have the next slide. Is it okay with you?
This would be easier because I'm not knowledgeable with a GoToMeeting, and it might take me some time until I find my way.
No worries.
Yeah. So just a second. Here we are.
Okay. And what I need now is to find out how I can share my screen with you. I already opened
maybe because you shared the moderation, now you can't. I have to cancel it so you can take over again.
Okay. Yes, you are right.
Yeah. Okay. Meanwhile, I'll be very glad actually to know who's around the table. Maybe somebody can do me a short introduction about the people there or countries, or because we don't have time really to do to the table. But I have an excellent exercise for you as a beginning, and it is according to some of you, if you can just share with us how would you define access and good access from your point of view? Just few pickups with your name, and then what's your understanding about good access, especially now we had kind of an access crisis in many ways with the COVID, and probably in some countries it is still there. So with your words, 2 words probably. Does somebody want to stand and kick off?
Probably ladies first. Is it okay with you? Just some words about us, because I'm really afraid that we are running out of time.
Yeah.
What do you think about Daniela starting as the president of PHA Europe?
Sure. So Daniela,
Daniela, unmute you. Unmute yourself.
Sorry, do you hear me now?
Yes.
Yes.
Yeah. I am a president of PHA Europe. I will be very short. Gergely catch me on the. Well,
Good.
okay.
Yeah, go.
We talking about patient access partnership.
No, we're talking about access. From your point of view, what is the good access?
Access to media, to another association, to actually community.
Actually, you answered already your question. So access has different dimensions. It could be access to
Yeah.
medicine or to community or to information or to doctors. Any other opinions about access for you personally? What is access?
Well,
sorry.
Yeah, somebody?
Today.
No, I just want to add that maybe access, I understand it like this is all access to whatever it is connected to our health, to our disease. So yes, with media, if you are trying to raising awareness or access to doctors when you need treatment, access different area. I understand this presentation that it will go in this direction. If you ask this question.
Yes. Actually, I ask everything with only one word, access. And where are you from?
I'm from Slovenia.
Slovenia, good.
From
Any
Slovenia,
other? Yeah,
no, I just, when you ask if we can present ourselves, I'm coming from Slovenia. I am a PH patient, but this is because of my heart problem. And I'm 2 years after a heart transplant, so still working in association where we are raising awareness about this disease.
good. Hopefully, I will have opportunity to hear the others as well, and who they are. But actually, today my presentation would be, because it's end of the day, probably you're tired. It will be more or less questions. So get ready and your brains to be ready for any surprising questions from my side. But you answered very good, both of you, on what's access. Depends on what point of view you have. This is access. For some people, access might be access to media. For others, it might be access to doctors. For doctors, access might be access to quality information and trainings. It could be the same for the patient. For some, this could be access to life-saving medicines. So access has different dimensions, but all about us being well and receiving the care, the knowledge, and the treatments and the products that we need in order to fight better our diseases. So after this introduction, can we go through the slides? The next two
Yeah.
slides we can simply skip because you already presented who I am. Yes.
I don't know whether you can see the slides or
Yes.
also the. Okay.
Yes, it's okay. We will see them.
Go to the next. The people already understood who I am. Next. So the patient access partnership was actually, please keep the previous one. The patient access partnership
This one?
is, no, the previous one. Yes, this one, the vision, mission, and objectives. The patient access partnership is a multi-stakeholder platform based in Brussels, where we tried to get together all the different aspects that you already mentioned, kind of the doctors, the hospitals, the pharmaceutical industry. Of course, patients in the center, because this is an initiative that's initiated by patients and led by patients in order to find a common understanding about what's access. And guess what? It was not easy, as you saw, with only two interventions, to understand what is access. Access has really different dimensions for every person, and depending if you're a doctor, access is one thing for you. If you're the patient, the access means absolutely different thing for you. And at the end, access is altogether in place, properly sticked. The Access Partnership tried to do a definition. A definition that can make it a bit more clear and easy to measure access. Why this is important? Can we go to the next slide? Why this is important to measure access. In one of our next slides, I will introduce you to the concept of the 5 ways, and as well about importance of measuring, because if we cannot show why access in Slovenia, for example, is much better or worse in Bulgaria, we have to say why we assumed and we came to this conclusion that access is different. We have to have similar things to measure in order to be possible to change those things. But before that, to tell you a bit more for PACT. PACT already has these different points of view. And as you can imagine, it's not easy for us to agree even on a single topic. Sometimes what the industry would agree would be something that patients and doctors would probably oppose. Other times, the members of the European Parliament would propose, for example, legislation, as right now we have kind of some ideas in the European Parliament, members of the Parliament to propose kind of enforcement of the debate about the new COVID vaccine. Once it is there, to have compulsory licensing, which means that basically the company that develops the vaccine will not have license, but everyone around the globe can produce the vaccine for free. So that kind of things create controversy and might be a big issue between stakeholders for things not to move in the interest of everyone. We need to sit together and to find our way how we can find those cross-matching issues that will help us to move the agenda forward and to improve people's life rather than be stuck in one and the same conversation, who is right and who is wrong. The next slide. Next, please. So PACT is really trying to find these consensus understandings and definitions and to drive these initiatives that can help us move the agenda so it can change our lives. CE for Health is another network which is specially designed for Central and Eastern Europe. This is a relatively new organization, and we will be talking later on for those of you who might be interested to join this network of experts, where we are trying to address the issues in our region and to be capable to drive the political agenda in our own region through the local expertise and of course stepping and using the wider European context and tools that we already have. So C for Health is, I would say, kind of a smaller daughter of the Access Partnership, but really working with the local experts, and sometimes we are doing joint initiatives together. Next. This is about a conference that's coming soon, and my colleagues from the office will contact those of you who might be interested to join. But as we started our talk about what is access and access for you, and we understood that access is very different. And then I told you that one of the first things that we needed to do is to define access. Next slide. And next. This is how we came to the so-called 5 A's definition of access. I started with the measurement, if you remember, because this is Peter Drucker. He's a very famous, actually, mathematician, and he's defining access in a very interesting way. You cannot manage, you cannot change something if you cannot measure the something. So in order to be able to change the situation with access in your country, you have to be able to measure it, to compare it, and to appoint some really concrete evidences why it's different in your country and how a change could potentially benefit your country. Now, to keep this example very simple and keep it back to the COVID situation, imagine how much money we could have saved if we invested only 10% of what we lost in 2 months' time during the COVID. So it's very easy to provide this measurement to your governments. If they calculate how much money we lost now in the economic crisis that is ahead, it will be tremendous amount of money that the entire world. And if we invested in the last 10 or 20 years, only 10% of that, probably the tragedy with COVID would never have happened in the way it happened right now. This is a measurement, and this is an argument, and this is a way to manage the situation with access. That's why defining access and providing evidences is actually key for the work that we do, and engaging with policymakers and other stakeholders lays on common interest and ways to find this common interest between us. Next. We have done quite many questionnaires and different ways to measure access, and I'm not going to talk about these methodologies right now, but I will talk about something very interesting that actually came to our mind when we were developing the concept of access in order to make it even more complex, probably, what is access at the end. So next slide. Yes. So the 5A's principle is based on literature review. So we did a literature review and we were thinking, what are the definitions of access here and there? And based on the literature reviews, actually, we found out that there are 5 different ways of explaining access. This is how we came to the 5A's concept, and you will see that each of these ways actually has its place when we define access. And it's important for us to measure access. Why? To change the policy and to change the situation in our countries or in our cities or in Europe. So the first one, everyone, when we're talking about access, is about availability. If some product is available somewhere, if this is a medicine or if it is a medical device, is it available? Is the usual concept of access. If it's available, it's accessible. If it is not available, there's no access to it. Yes, but guess what happens if we have the product available, but the product is not affordable? So we have it there, but we cannot afford to pay for it. Do we still have access to the product? No. Because as far as we cannot use the product, it doesn't make sense to have it. Then imagine if the product is available, it is affordable, so we can buy it, but it's physically not accessible because we have to travel the entire country. And by the time when we travel and go to the shop, for example, where we can receive the product, the working times are already over and we have to go back all the way back. And this happens every day. So if we have the product, it's affordable, but it's not physically accessible, still the product is not accessible for us. So accessibility, the physical way to get the product, is another aspect of access. Then imagine if we have available product, affordable product, accessible product, so you can get it every time when you want, but the product is not exactly the product that you need. For example, if you need the right shoes, but you have only left shoes left available right now, do you have actually access to the shoes? No. So the product should be adequate according to the needs, according to each patient individual need, and this should happen, guess when? At appropriate time, at the time when the patient would need it. not after the patient is already with complicated condition, not when the doctor is back from holidays and it's too late for someone, but appropriateness is actually the fifth dimension of access. I hope with this example you understood that all 5 A's actually explain the same thing. And if any of these elements is missing, we cannot say that something is accessible. Do you have questions around the 5 A's? Everything clear? Someone from the
Everything is clear. Very
good.
good point of view.
So how can you use this tool? Maybe someone from the boys who are hidden there behind the camera, behind their computers. How can you use that in your daily life when you're trying to change your system? For example, if we talk about access to some treatment.
I think it can be used as an analysis. So you can walk through regarding your respective country, your respective needs of medication, and you can, have a paper in front of you and check what is the problem that I do not have access to the medication I need, whether it is due to the reason that it is too expensive, or for instance there are some other barriers, and you can check at what stage you are stuck with this flow.
Exactly. So actually this is a very interesting tool for you to measure anything in the healthcare system. You can measure, for example, access to doctors. So are they available? Are they affordable? Are they physically accessible? So are they equally spread in your country? Are they adequate? Do they have do they have adequate time, for example, for you? And do they have the knowledge that you need? And are they appropriate? Is the healthcare system structured in such a way that it meets your needs when you have the needs? So you can use that to measure your government. You can do that to measure your health minister or head of unit or whatever. So this is really kind of our pact universal understanding of access, and these 5 different aspects of access became kind of one of our tools to evaluate the systems, to compare even countries. So you can take your disease area, you can take even element of it, like transplantations only, or access to early diagnosis, or anything that you can think, and compare 5 countries based on these 5 different criteria. And then voila, you have a very good a data set based on responses of your membership, for example. And imagine what will happen if you do that, not only among patients, but if you ask their relatives, and how these differences are actually affecting their lives. Or if you do that with the doctors, or if you go further with the pharma industry, or if you do that with anyone else that is relevant to your concrete situation. But as we said in the beginning, why do we need all that to produce the next set of data? We need that in order to be able to start a conversation and to lead this conversation to real change for our lives. Can we go to the next slide? Yeah, it's a bit lagging. Good. And the next one, because I already explained this, that we can use this concept to go to different areas, etc. So how can you contribute actually on local and European level to change the situation and the issues that you already said you have? And I would really like to spend the next part of this session of thinking how this could be used and what the benefit can be. And now is probably the time that we start kind of thinking whether any part of this is useful for your daily work. And can I ask some of the people who have not been online yet to share their views on this tool? Do you think that you can use it in some way in your country or in your organization if you're involved in a bigger structure or national umbrella, or together with your policymakers?
Probably nobody is willing to speak with us right now, but I think yes, it's very good idea and good advice.
So
We can use it.
you personally, how would you use it?
Well, I will start with the first thing. It's accessible and it's first point what you speak about. I probably should see if I have good access to some medicine or a doctor. And next point is if I how I can approach them. If I can't approach them, I will do something to resolve the problem. So if I have doctors, medicines, and I have approach and accessibility, then I will go to the next level. So it's the same for the focusing to UA level and to regional level.
Regional.
We should start with the first point and first problem.
Good. So I would like now everyone to think about the biggest access issue in your own country. So we will do the round starting from you, since you have your microphone open. And please, everyone, go online and only tell me which is your country and what is the biggest access issue that you have there, according to you.
Okay, so
maybe you guide me and introduce me to all of them, and we start this round tour.
yeah, let's start with Arya. I try to unmute, but something is not working. But yeah, so Arya is from Israel, so it is a little bit different legislation they might have. So we are really looking forward to what
Can you hear me?
is the situation with you, and how do you think it can be managed based on this, proposal?
Yes, we can hear you, Arya.
You can hear me. Okay, so in Israel, the main problem is a DEM pass, that we don't have the accessibility for a DEM pass is only for PH patients that have CTEF. So, so the other medications are available for all the patients, but a DEM pass is available only for CTEF patients.
And have you already, checked these steps what Stanimir mentioned, that where it is, the process stuck? Is it due to affordability or some barriers of export or import restrictions, or do you know where is the problem that other medications are available for the patients, but Adempas is not available?
It's because of the government that they decided that Adempas is not proof. They didn't prove enough. The company didn't prove enough that it's it's very good also for other PH patients. That they did improve it, that it's very good for CTEPH patients, but they didn't improve enough evidence that it's very good for other PH patients.
Good. This is a good point of view. So we have here a very specific occasion where we can use this tool, and we understood that actually more data is needed, or other ways to put pressure on the governments. But I'm afraid about the time. Can we go faster by the others? Just say your name and the biggest access.
Yeah, let's try with Ukraine, and Hal, probably you can help Andrei.
Yeah, okay. So my name is Hal. I'm from Norway, but I know the situation in Ukraine pretty well because I'm married to the president of the Ukrainian Association. And if you look at the Ukraine and look at Norway, you see a big difference. In Norway, we have all the treatments available, and we have access to good hospitals and good hospital care. And the situation in Ukraine is very different. They don't have access to all medication, limited access to a few of the medications, and I think also the access to proper medical care is also not so good. So yeah.
But even in Norway, from your Norwegian perspective, what is the most common issue that the Norwegian patients, for example, want or consider to have as a problem of the system, for example?
Yeah, I've been trying to think what
or complain of.
Yeah, what would it be the biggest problem? You know, we are a very far-stretched country, geography-wise. So maybe when you talk about the accessibility, that, for instance, a person living all the way up in north, it will be hard for him to travel to Oslo in the same way as the people living there. But at the same time, you do get paid flight to visit your doctor if you need so. But it's geography-wise, I think maybe that could be one challenge. But also, I see with my wife, she was just she just came to Norway, and that now I try to get her hospital treatment, and the first appointment we got was in October.
Okay.
So, and I think this is a little problem that it takes a little time, but I guess it's the COVID situation and all that.
Good, but Norway has low mortality and prevalence of COVID, yeah, like Bulgaria. We somehow did it. Good. Other opinions and access issues in your countries?
Katica, would you mind sharing the situation in Croatia? I was really thinking about Sabina from Bosnia, but she wrote that she's in a traffic, but probably Sabina after Katica, you can jump in. So Katica?
Okay, hi everybody. Well, the access in Croatia is actually, well, for Eastern European country, pretty good. So we have hospitals, we have really good doctors, and we have access to all the medicines available on the market in Croatia. And they are all on the A list, so they are refundable.
So you think nothing should be changed in Croatia? Patients are satisfied?
Oh, yeah, there's plenty of things that should be changed. But I'm just saying, in comparison to other countries, we have it quite good.
When you talk about medicine, so tell me
Sorry, it's breaking. The line is breaking, so I can hardly hear what you're talking. Could you repeat your question?
Yes. My question is, what are the access issues that you have? We know that each country has some good things, and that's very good, and hopefully all the countries will be best someday. But tell me, what is the thing that you would change in your country?
Well, the waiting lists. This is a quite bad situation in Croatia. We have to wait for a long time to get the appointment with the doctor. And the other thing is, it takes quite a bit of time to actually diagnose the right diagnosis for the patient.
So, just a second then. You said that you are very satisfied with the doctors, but at the same time, you're not satisfied with the waiting list because the doctors are obviously not enough. And
Yes.
that it takes time to the diagnosis. It means that doctors are not adequate. So you have good doctors probably on words.
No,
But
actually, I'm talking about our GPs. The doctors, they were supposed to send patients to the specialists. I'm talking about them, and as well, I'm talking about the administrative side in the hospital. So the doctor is not the one who says, okay, I can see you next week, or I can see you in a month. It's basically the administration. It's pretty bad.
good.
But I don't think it's only in Croatia. I think that's widely spread everywhere.
Good. So, but you agree that these are the major issues there, and I think
Yes.
the most important thing that when we talk about access is actually to focus on where the gaps are. And regardless how much we like the system, we have to be very much criticizing our systems in a constructive way. Because it's easy to say to the system, we have, for example, or this is the concept of the politicians very often. They say, oh, we are much better than everyone else, therefore you have to wait for ages. This doesn't help your patient. I'm sorry, but this is not helpful to any patient. And this is just a good way for them to close our mouths. And when we have solid arguments and when we have solid data, like telling them, yes, you might think that we have everything, but we have longer waiting times than Bulgaria, for example, or Serbia, or I know that Croatians like to compare themselves with some of the neighboring countries, then you have solid arguments to anyone why they need to drive this change. Because regardless of how good politicians they are, and they probably are, and regardless how good doctors they are, and probably they are, they also have to take a step further and train their colleagues, the GPs, in a very nice and good way, so the GPs can understand and the GPs can start sending the patient earlier, for example. Good. Any other access examples? Even in Norway, we found access issues, and it's true. There's every country where we can find an access issue, and every time we have to work towards improving our systems until the time when we see healthy people. And sometimes this is not possible, unfortunately, and there are diseases that don't have kind of treatments, magic treatments that everything will be back to normal without the disease. But we can try to make people's life as much better as we can. Good. Do we have someone from other country maybe that we haven't heard?
Yes. Would you mind, Rima, to tell us what is the situation in Lithuania?
Mm-hmm.
I try to pick, countries where might be some problems because, in Austria or in Norway,
Exactly.
however,
I would like
not
yeah,
all,
as well.
there's no problem. But if Rima is not really, cannot contribute, Peter, Slovakia, do you have everything you need, or is there any way of improvement of access in terms of what has been previously discussed? You are unmuted, Peter, but we cannot hear you. Hello?
Mm-hmm.
Then let's try Dora from Hungary. Dora?
Sooner or later we'll have Austria.
Can I ask a question? Because one issue that was raised was this thing about time to diagnose. And this is an issue in all countries, including Norway, that it takes a long time to diagnose because this is a difficult disease to diagnose, and maybe the knowledge of the general practitioner is not so good on this disease. In which of these 5 A's would this be categorized as a problem?
Yeah. So I'm sure that there are reasons for the diagnosis to be so long, and you mentioned already one of those reasons, and it's about GPs not being prepared enough and looking enough for this disease on time. Yeah.
Yes, because this is a rare disease. Not many patients will show up at the doctor's office and so on.
Good.
And so, also the symptoms are very common, so it's hard for the doctor to understand that this is this disease.
And
which one of the 5 A's would this categorize under?
It goes to is it because there are lack of tools to do this diagnosis, or lack of knowledge of patients? Where's the problem according to you? If it was you to change something in the system, what would you take and change it?
Well, the symptoms that the patient with this disease has can be easily mixed with less serious disease, with people with asthma and so on. So I think one important thing would be that if there is a person that comes with a shortness of breath issue, that maybe the doctor could send this person to a specialized centers where they have specialized in patients with shortness of breath to do further diagnosis.
So you're telling me that there's lack of guidance to the doctors what to do when they have a patient with this symptom, which might be neglected, shortening of breath. Is that correct?
Yeah. I guess you can say
may I jump in? Sorry for
Yes,
interrupting. Sure. I think that the main question here is whether these 5 A's can be adapted to services, because now we are not talking about products, medication, drugs, but a type of service we are expecting from the healthcare system. So it's a late diagnosis, lack of multidisciplinary team, and such kind of services. So the question is, once we are lacking of such type of tools we need in order for us to be diagnosed in time, what do you think, at what stage we are stuck? Because we have GPs, but probably they do not have knowledge. But even if they do have knowledge, the PH patients need to visit different hospitals, different experts, and it may take time. So it is really difficult, I think, to tackle where is the problem in such kind of situation.
Yes. Have you been comparing all the countries and to tell me where is the best and the fastest diagnosis in which country?
You know, it is one of the difficulties here is to find out solid data, because it might occur that some of the patients are lucky and they meet a GP who can directly refer them to a PH specialist. But on the other hand, there are some data which suggest that it may take up to 3 years to appropriately diagnosed.
In which country?
It depends. It does not depend on the country, because if you are unlucky and visiting and running the same circles, it might occur that it is in Norway or it is even in Bulgaria. So due to the fact that it is a rare disease, it is very difficult to provide a huge amount of data, and so it is challenging to to provide
solid data.
good examples in terms of this.
But I'm sure that you can find cases of people who have been diagnosed fast, and what are the factors that has been leading these people to faster diagnosis, and cases where people have been diagnosed very late, and what are the key factors why their diagnosis was prolonged. So you can at least have some criteria about which system or which intervention works better and which is not working better. Probably.
Yeah, that's true. Probably we should build up some patient cases to find out where is the hardest points in terms of appropriate diagnosis.
Yes.
Probably we can make it on a scientific level. But in the meantime, we received some additional comments in the chat box. I do not know whether you can see, Stanimir. One is coming from Slovakia. Transplant issue that they do not have locally a transplant center. Sabina also joined us via chat that it depends on where they live, because they have lots of regions in Bosnia and Herzegovina, so it is also challenging for them. So we have lots of problems, as you can see, in terms of access, and once we are talking about more and more, we just realize that even that we have access, it is not the best way we have access.
Exactly. So we saw that access has different dimensions. Actually, the 5 ways are very relevant to services. As far as you know which service is needed or not needed, you can measure very easy whether it's appropriate, accessible, affordable, etc. But you have to identify somehow what works better and what not. You have to identify what and how you define an ideal system for your disease area. And this is going to be actually the last part of my presentation about the importance of common understanding between the community, so between yourselves, being representative of the patient's community, but also the experts. You have to define what is the perfect accessible system based on your knowledge and experience up to now. Why is this important? Because then you're never going to enter in a conversation how you collect data. You probably will have lots of challenges to bring all this knowledge and to build the model of excellence. But in the model of excellence, I'm sure it will be written that every country should try to have faster diagnosis, and the faster diagnosis up to now, this and this type of interventions and policies have been shown to be much better if they are in place rather than not being in place. I'm simply without knowing the concrete examples from your countries, but I'm sure this could be defined. So then all the countries can start measuring very well if they have these services properly organized in this country or not. And then they can easily know what needs to be managed in every country in order to improve the timely diagnosis if this is a problem. So I hope you get and you start understanding my point of the last part of the presentation. But can we really do more as patients community on European level, even on regional level, to define what we want? We all know the situation is not perfect anywhere, and challenges exist. Sometimes it's about rare disease. Here I read very well the comments coming from Rima and from the others that in Bulgaria we also don't have transplant centers. Our patients need to go to Vienna, which is even further than We are not even neighboring countries. And recently, Vienna, they stopped the contract with everyone, even with us. And I mean, we all have common problems, but we never sat together and said exactly what we want and how we define a perfect system, a perfect world where patients and doctors would have everything in place. Somebody has to say, what is this everything in place? Does it mean doctors? Does it mean clinics? Does it mean tests for every person who is going to the GP? Or it means something else? But you are the people who only know in this world what is missing and how it could be and how it should be. So let us go very fast through the next slides, where I will try to encourage you to take this step, and you as community, together with probably your doctors, to define what's needed. Further? Go? More? You can read those slides. These are just some examples of techniques that you can use, but this slide, please. Many of you probably are aware that the European Union, before the COVID, but after it as well, finally, some politicians decided to prioritize one disease area, and they wanted to create the so-called Europe's Beating Cancer Plan. For the first time ever, some politicians decided that it's important in Europe to have a common plan for disease. Somehow they decided that cancer probably is very sexy and it affects lots of people, and it's probably they have thousands of arguments why cancer is in the focus. But I personally do believe it's a very good thing that this happens in Europe, and for the first time ever, this process would be led by the European Parliament. Maybe many of you have questioned yourself when Europe would prioritize any rare disease. Shall we wait 5,000 parliaments and 5,000 different politicians to come to the idea that they have to prioritize certain disease until our own disease is prioritized? Actually, I would say no. We shouldn't wait for the politicians to prioritize and to create on our behalf the action plan. The people who are going to create the action plan on cancer right now, guess who they are? Of course, the politicians are part of that. But actually, these are the same people as you, cancer patients from around the Europe and different cancer organizations on European level, as you are European organization umbrella, but also you are local organizations. So many of them will be involved in one or another way. It will be doctors, the same doctors that are taking care for you or for the cancer patients. They will participate on national level on different debates with their consensuses and their science that they're doing, but they will also participate on European level through the European associations, and they will be consulting the European Commission on how this plan should look like. It will be public health experts and public health organizations, and I'm sure you know many of them, who will be sitting around the table and providing expertise to the politicians. And I'm sure you also know many politicians in your countries and probably on European level who the same politicians are going to be invited to work and to be part of these events and meetings when they're going to drive the cancer plan. So my question is, can any patient group around Europe start creating in exactly the same way their own European plans without waiting this to be established officially and formally as priority in the European Union? Because many diseases in disease areas, they already know what needs to be done. We know that in Norway you have to improve the the accessibility, because Norway is 4 times bigger than Bulgaria and the distances are huge, and it's only half of the population of my country that lives there. And we know that you have the fjords that's making the land, the landscape really difficult, etc., etc. So you probably know exactly what needs to be done. And it's the same with every single country. The only thing that we have to do is actually to agree on all that, not only between us, I mean the patients community. We have to agree about what matters with the doctors. We have to agree with the countries. We have to find this consensus with politicians, and we have to find champions to drive this agenda. Only then we can have a unified approach and really good advocacy tools to fight for better access based on evidences. And evidences should be collected from real life. And when they are not published and not enough patients, we still can provide evidences, which could be different case scenarios and reports. But I'm sure there are lots of evidences also published scientifically in any disease area. So my call to you would be, don't wait 5,000 years and 5,000 parliaments. We're not going to be alive then. We're encouraging currently different disease-specific groups to see, even regional corporations, to start in different diseases and to agree on these plans and start pushing your governments and start pushing the European institutions. And this is also our role, once we have this kind of consensus documents and plans, to push the Commission and to ask them, if you agree to implement and recognize the cancer plan, why would you refuse to recognize the pulmonary hypertension plan, since it's done through exactly the same way, with exactly the same methodology, with exactly the same stakeholders involved, and there's no reason for them to refuse to implement that. With this, I hope I've been throwing the glove to you, and hopefully have given you some ideas what can we be doing and not waiting 5,000 years, and what concretely we can do in order to involve others to understand about our topic, and how we can prioritize our disease and create really tools to put pressure on our governments and to point them exactly what needs to be changed in every single country, even in Austria and in Norway.
Just one comment from me. This sounds very good, all, but I think we might encounter one problem, which is that which is the money. Some countries are rich, can afford much better care and access to medication and so on than other countries. And it's if we make a plan that we plan to have all available medication for all patients and all this, I'm afraid it can in some countries just be empty words, because they simply don't have the budget for it.
Exactly. Very good question. And actually, that's why you need European approach, because this could be a very good way to convince everyone that at the end you can have kind of European purchase of medicines when we talk about rare diseases. And this is the way where you can convince European leaders that European solidarity is needed, and some countries are in really difficult situation in providing the medicines alone to their citizens. And this is where actually their investments should go, rather than investing in things that have absolutely no economic or health effects, but just spending money, as we have seen lots of times in the past. So this is an opportunity, and it's not a problem. I would say this is really an opportunity to be creative and to think with the others.
Do you have any advice for countries which are not in Europe, let's say Bosnia and Herzegovina?
Well, all of them have declared their willingness to be part of Europe. And you know that during the Bulgarian presidency, there were quite many kind of steps towards that, also on European level. So I wouldn't mind, and I wonder whether anyone would oppose if they include it in this kind of this kind of debates, because creating a model of excellence in a disease area is valid regardless the country you live. And especially if you are a country that, as the Western Balkans, who are willing and at least declaring their willingness to get closer to EU, and this should be the way, because at the end this is the most natural allies to these countries and the natural way forward. And when the EU is actually not closing the doors, still giving indications that this might happen, I think it's even easier for them to put some pressure on their governments. But here, we, the countries who are in EU, have the role to convince EU that we have responsibility to our future members and neighboring countries, and we cannot abandon them and say, okay, do your own thing, do whatever you want, and once you become our members, we will think of you. It's simply not possible. It's our joint responsibility to go through this process.
I think that maybe a way to convince the government sometimes is to convince them that there are medicines that are not very expensive, like the
Exactly.
Viagra, the Revatio, and so on. So you can convince them that there are a lot of kinds of medicines, and some of them are very, very expensive. But if they can only at least approve one of them, the cheapest one, after you have something inside the system, it's already more easier to convince them to approve another medicine. But first of all, to try to push them to the cheapest one, and then after you're in the box already, so it's already easier to go forwards.
True. In any case, having joint agreement on European level about what it should be is already a good tool in your hands to go to your government and say, okay, listen, this is what it has to be, and here in our country we have nothing of that. So let us see how we can start.
Yeah, many thanks, Tanimir. I think it was a fantastic, webinar, and you really fantastically involve us in lots of questions. I think that it is only a beginning of our discussion regarding access, because as I mentioned in my introduction, there are lots of problems in terms of access, especially in the Balkans. So I think that it was a very nice kickoff of this subject, and we are also planning to launch a working group, and we hope that we can work together in C4 Health and PACT to make better access, not only in the European Union, but also in other countries who are part of our big family. This webinar was part of our World PH Day celebration. I'm really happy that you joined us, and many thanks again, Stanimir, for your excellent talk, and have a nice evening to everybody.
Thank you very much.
Thank you.
Next
Bye-bye.
time, discussing concrete things on how the things would happen, and pulmonary hypertension being one of the first disease areas, among others, who indicated that they're willing to take this path.
Thank you very much.
Okay, thank you.
Bye.
Thank you.
Bye.
Thank you. Bye-bye.
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 Nice to see you.
Bye to
Bye.
Thank you.
Bye.
Feedback.
Bye. Bye. Thank you very much. Goodbye to all.
goodbye.
Thank you.
Bye to all.
Bye.
Coffee break. Bye.
Bye.
Ciao.
Ciao Vittorio.
Ciao.
Ciao.
Ciao. Così.